Welcome to the Deep Dive, your shortcut to being well-informed. Today, you're embarking on a really crucial deep dive into the delicate, intricate world of high-risk newborns. Imagine being able to quickly grasp the essential assessments and interventions that can, well, literally make all the difference in a tiny life. That's our mission today. We're sifting through your sources to pull out the most vital insights for identifying these vulnerable infants, understanding risks tied to maturity and size, spotting maternal infection impacts, mastering strategies against cold stress, deciphering jaundice types, managing respiratory distress, and addressing the unique needs of babies born to diabetic or substance-abusing mothers. Our goal? Equip you with clear, actionable knowledge from these sources, focusing squarely on key nursing assessments and interventions. Get ready for some critical insights.
Okay, let's unpack this. Our sources kick off by defining what makes a newborn high risk. Often it seems to be about, when they arrive or how big they are, but there's a deeper insight here, isn't there? Absolutely. What's really fascinating and critical for nursing assessment is how that level of maturity, specifically prematurity, it doesn't just correlate with complications. It really dictates a whole different set of physiological challenges.
Okay.
Being born before 37 weeks isn't just arriving early. It means crucial developmental steps just haven't happened yet. It introduces this cascade of risks.
Right.
So for nurses, assessing prematurity involves looking for those telltale signs of underdevelopment. Think smooth, almost translucent skin,
Okay.
more fine lanugo hair, that general hypotonic or less flexed muscle tone.
That's resistance.
Yeah, exactly. And ears that might fold down easily because they lack cartilage, their reflexes might be diminished, their cry weaker. And these aren't defects, they're normal characteristics for that gestational age. But they're direct flags that this baby is uniquely vulnerable outside the womb.
So those physical signs aren't just little details, they are critical indicators for nurses. Immediate red flags that this newborn is high risk. But beyond prematurity, size also speaks volumes, doesn't it? You mentioned sources highlighting small for gestational age, SGA, large for gestational age, LGA, even babies who stay in a bit too long, post-mature.
Precisely. And each category presents distinct challenges and demands specific nursing assessments. Let's start with small for gestational age, SGA.
Okay.
These are babies whose birth weight falls below the 10th percentile for their gestational age.
And why does that happen?
Often it traces back to issues like placental insufficiency, maybe maternal infections, smoking, hypertension, poor nutrition, even substance abuse. So when a nurse assesses an SGA infant, they're looking for specific things. Loose, dry skin, maybe very little fat or muscle mass, not much scalp hair, a weak cry. And crucially, from an intervention standpoint, these infants are at high risk for hypoglycemia, that's low blood sugar and cold stress.
Right, which we'll definitely get into more. So that's SGA. Then on the other end, we have the large for gestational age, LGA infants. What are nurses looking for there?
LGA babies, their birth weight is above the 90th percentile. While the exact cause isn't always known, a major factor we see is the infant of a diabetic mother, or IDM.
Okay.
When assessing an LGA baby, nurses aren't just measuring that high birth weight, they're also keenly looking for signs of birth trauma.
Like from the delivery itself.
Exactly. Things like a fractured clavicle or maybe a nerve injury like Herb Duchenne paralysis, which can happen with shoulder dystocia during a difficult delivery. These infants are also very prone to hypoglycemia, especially if the mother is diabetic. And they can have polycythemia.
Polycythemia.
Yeah, too many red blood cells. It makes their blood thicker, can cause problems, and often you'll see really ruddy skin. And that excess of red blood cells, especially if they get damaged during a traumatic birth, can also lead to hyperbilirubinemia jaundice.
Okay, so lots to watch for with LGA. And then finally, the babies who arrive late. Post-mature infants. What are their unique assessments and complications?
Post-mature infants born after 42 weeks, they bring their own set of risks. Nursing assessment focuses on an absence of vernix, that creamy coating.
Yeah.
Gone. Minimal lanugo. Their skin is often really dry, cracked, peeling. Sometimes they have long fingernails, maybe even scratches on their face or body from being in there so long.
Wow.
You might also see yellow to green staining on the skin or the umbilical cord from meconium passed in utero.
Okay, so that's a sign of distress.
It can be. These babies are often hypoglycemic because they've used up their glycogen stores, and they have very little subcutaneous fat, making them vulnerable to hypothermia or cold stress. The biggest nursing concerns here are things like meconium aspiration, fetal hypoxia during labor, potential neurological issues. So interventions focus heavily on assessing for signs of hypoxia, checking the airway for meconium, looking for birth injuries, and absolutely maintaining that neutral thermal environment and starting early feedings.
Right. So now let's zoom in on those immediate, sometimes life and death challenges. Starting with the most fundamental need, breathing. What does a nurse look for when a newborn is struggling?
This is absolutely top priority for nursing care. Respiratory distress syndrome, or RDS, it's particularly concerning in premature infants. And here's the key insight, the pathophysiology. It's often due to insufficient surfactant.
Surfactant. That's the stuff that keeps the tiny air sacs, the alveoli, from collapsing, right?
Exactly. Without enough of it, those alveoli struggle to stay open, makes gas exchange incredibly difficult. So the nursing assessment involves looking for clinical signs that usually pop up almost immediately or within an hour or two after birth.
What kind of signs?
You'd see pedyspnea, rapid breathing, visible retractions where the chest wall pulls in with each breath, sometimes a seesaw motion between the chest and abdomen, audible expiratory grunting,
Grunting, okay.
nasal flaring, increased oxygen needs. Their skin might look gray or dusky, breath sounds could be decreased, or you might hear crackles, and the baby might just be lethargic, hypotonic. Later, more serious signs include hypoxemia, acidosis, tachycardia, a fast heart rate, and eventually profound lethargy and even apnea, those pauses in breathing.
Okay, so when a nurse identifies these signs of respiratory distress, what are the immediate critical interventions? What do they do?
The nursing care has to be focused and swift. Maintain respirations ideally between 30 and 60 breaths per minute, assessing them frequently, like every 1 to 2 hours.
Okay.
Administering oxygen as prescribed is crucial, aiming to keep that oxygen saturation above 90%. And here's a key intervention. If the respiratory rate climbs above 60, you hold oral feedings.
Why is that?
High risk of aspiration. The baby just can't coordinate sucking, swallowing, and breathing safely at that rate. Positioning is also vital. We often place the infant side-lying or supine with the neck slightly extended, sometimes even prone, which can help lung expansion in some cases.
Prone?
And suctioning the airway as needed, keeping it clear, plus continuous monitoring of oxygen saturation and blood gases is absolutely non-negotiable.
Got it. So beyond breathing,
Mm-hmm.
keeping these little ones warm is equally critical, right? Especially for preterm infants. Cold stress sounds like a major threat.
It truly is. Cold stress isn't just about feeling cold, it's a major metabolic drain.
Oh, so.
It forces the baby to burn critical glucose and oxygen just trying to generate heat. That diverts vital resources away from growth, healing, everything else. And premature and SGA newborns are especially vulnerable. They have a huge surface area compared to their body mass. They lose a lot of heat from their heads. They lack that insulating subcutaneous fat.
Right.
They have small muscle mass. And crucially, they can't shiver effectively or sweat to regulate temperature like older children or adults.
So it's a perfect storm for losing heat. What are the core nursing interventions then to prevent this life-threatening cold stress?
The number one goal for nurses is maintaining a neutral thermal environment, or NTE.
NT.
This means placing the infant under a radiant warmer, or maybe inside a double-walled isolette. We warm everything that touches the baby, the oxygen, equipment, blankets, linens,
Everything.
everything. It's absolutely vital to keep the infant dry, especially right after delivery or during bathing. In fact, we often postpone that initial bath until their temperature is stable. Simple things make a huge difference. Putting a hat on their head, wrapping them snugly in warm blankets. And nurses are constantly assessing axillary temperature, aiming to keep it above 97.6 Fahrenheit or 36.5 Celsius. We're also watching their oxygenation and looking for signs of hypoglycemia, which often goes hand in hand with cold stress.
And if they do get cold?
If rewarming is needed, it has to be done slowly. Rewarming too quickly can cause problems like hypotension or apnea. Slow and steady.
Okay, slow and steady warming. Now, let's talk about jaundice. It's something, many parents expect a little bit of, but there's a crucial difference between what's normal and what's a serious medical alert, right?
Right. Absolutely. And this raises a really important assessment question for nurses. How do you differentiate between physiologic and pathologic jaundice? The timing isn't just a clinical detail, it's like the newborn's earliest alarm system.
Okay, explain that.
So physiologic jaundice, this is the more common, generally less concerning type. It begins after the first 24 hours of life.
After 24 hours. Got it.
It happens because newborns just normally have about twice the bilirubin load as adults. They have more red blood cells. These cells have a shorter lifespan, and their liver is still immature, kind of slow at processing or conjugating that bilirubin.
Makes sense.
Risk factors that can make it a bit worse include things like enclosed hemorrhage, maybe a cephalohematoma from birth infection, or delayed feedings, which slows down bilirubin excretion. Bilirubin levels typically peak around day 3 to 5, maybe a bit later, day 5, in preterm infants.
Okay, so that's the normal kind, physiologic. What makes pathologic jaundice so much more serious?
Pathologic jaundice is indeed more serious because its onset is within the first 24 hours of life.
Okay, much early.
Yes. And that early onset usually points to a more significant underlying problem, often hemolytic disease of the newborn.
Like Rh or ABO incompatibility.
Exactly. Where maternal antibodies are attacking the baby's red blood cells, this can lead to severe anemia, cardiac problems, even hypoxia. With pathologic jaundice, bilirubin levels rise much faster. The sources say more than 0.2 DLLs per hour. That rapid rise is a major red flag. There are also specific types related to breastfeeding that nurses need to assess for. Breastfeeding jaundice, or maybe better termed lack of breastfeeding jaundice,
Oh,
occurs in the first few days. It's usually due to ineffective breastfeeding and just not getting enough milk, leading to dehydration and delayed stool passage, so bilirubin builds up.
so the intervention there is...
Helps fix the latch, encourage frequent, effective feedings. Sometimes supplementation with pumped milk or formula might be needed temporarily. Then there's breast milk jaundice. This has a later onset, usually after the first week. It seems to be related to something in the breast milk itself that increases bilirubin circulation.
Right.
It tends to peak around 2 weeks.
And do you stop breastfeeding then?
Usually no. Breastfeeding typically continues unless bilirubin levels get extremely high, then a temporary interruption might be considered.
This sounds incredibly complex to manage. When a newborn does have jaundice, especially if it requires phototherapy, what are the absolutely critical nursing responsibilities? What must happen?
Well, first and foremost, the crucial initial intervention for any hyperbilirubinemia is early and frequent feedings. That helps the baby pass meconium and stool, which is how bilirubin gets excreted.
Feed the baby.
Feed the baby. If phototherapy is started, the nursing responsibilities become quite extensive. You absolutely must cover the infant's closed eyes with protective patches or shields.
Eyes covered.
Yes, but you remove those covers regularly, maybe every 2 hours, for assessment, cleaning, and importantly, for bonding and eye contact during feedings. The infant needs to be undressed, except for a diaper to cover the genitalia, to maximize skin exposure to the special lights.
Maximize exposure.
Right. Nurses also need to change the infant's position every 2 hours or so to expose different skin surfaces and prevent pressure sores. You assess the skin meticulously for any breakdown or rashes. You monitor their temperature closely every 2 hours usually because they can get overheated or too cool under the lights.
Temperature checks.
Absolutely. And you watch their output. Look for those loose, often greenish stools. It's actually a good sign bilirubin is being excreted. But it also means you need to increase fluid intake, often IV fluids or more frequent feedings, to prevent dehydration.
Makes sense.
And of course, monitoring the bilirubin levels themselves with blood tests or transcutaneous readings is essential. For extremely high levels, an exchange transfusion might be needed. That's a complex procedure,
Right.
requiring specific Rh-negative blood, careful warming of the blood, potential administration of calcium gluconate because of hypocalcemia risk, frequent vital sign monitoring, and meticulous record keeping. Very intensive nursing care.
Definitely intensive. Okay, we've talked a lot about the baby's own physiology, maturity, size, but often the most critical risks stem from the mother's health during pregnancy. Let's shift our focus to those maternal influences. How do infections and substance use during pregnancy really affect the newborn?
This is where we really connect the dots, showing how maternal health directly impacts neonatal outcomes. It's crucial for anticipating risks. Let's talk maternal infections. Nurses need to be acutely aware of a group often called Tornos H infections.
Norse H.
Yeah, it's an acronym. T for toxoplasmosis. Here, nurses assess for severe issues like seizures, coma, microcephaly, hydrocephalus. Interventions include educating mothers on prevention hand hygiene, avoiding raw meat, cat litter exposure.
Okay, O is other, often includes hepatitis B, syphilis.
Right. For hepatitis B, if the mother tests positive, HBsAg+, the infant gets HBIG, the immune globulin, and their first hepatitis B vaccine dose within 12 hours of birth. That's a key preventative intervention. R is for rubella. Nurses assess for congenital heart disease, IUGR, hearing loss. Infants born with congenital rubella need to be isolated to prevent spread. C is cytomegalovirus, CMV. This can cause a whole range of issues: anemia, jaundice, hydrocephaly, microcephaly, pneumonitis, deafness. And H is for herpes simplex virus, HSV. This can be lethal to the fetus. If the mother has active genital lesions at the time of labor, a C-section is indicated to prevent transmission during vaginal birth.
Wow, Tourist covers a lot. And what about other sexually transmitted infections, STIs, passed from mother to newborn?
Good question. With other STIs, syphilis is detected via serologic tests, like the VDRL, on the mother or infant. For gonorrhea and chlamydia, the big risk to the newborn is sepsis and ophthalmia neonatorum, a severe eye infection that can cause blindness. This is why routine eye prophylaxis with erythromycin ointment within the first few hours of birth is such a critical nursing intervention. Standard practice.
That eye ointment, right.
Exactly. Candidiasis, or thrush, presents as those white patches in the baby's mouth or on the tongue that cannot be easily wiped away. The intervention is usually nystatin antifungal medication. And finally, HIV/AIDS. Transmission rates are drastically reduced with maternal antiretroviral therapy, specifically zidovudine during pregnancy and labor, and often a planned C-section. Nursing care involves standard precautions, supporting bottle feeding as the safest option in most settings, and administering zidovudine syrup to the infant for several weeks after birth.
Okay, so beyond those specific infections, a broader maternal factor that puts newborns at extreme risk is sepsis, right? A generalized infection. How does that manifest in a tiny baby?
Yes, sepsis is a huge concern. It's a generalized infection that spreads rapidly through the bloodstream. We talk about early onset, within 72 hours, late onset, even very late onset sepsis.
What causes it usually?
Common causes include prolonged rupture of membranes, say longer than 14-16 hours before birth. Prematurity itself makes them vulnerable, or a known maternal infection, especially group beta streptococcus, GBS. What nurses assess for is often subtle at first. A key sign is temperature instability. They might be hypothermic or hyperthermic, feeding intolerance, vomiting, lethargy, just subtle changes in behavior.
Subtle changes. Tricky.
Very tricky. Then it can progress to worsening respiratory distress, hyperbilirubinemia, initially maybe tachycardia, but then followed by apnea and bradycardia, slow heart rate. Lab work might show abnormal white blood cell counts. The absolutely crucial nursing intervention sequences: obtain cultures, blood, urine, cerebrospinal fluid before starting antibiotics, then administer broad-spectrum antibiotics and IV fluids as ordered, and observe vital signs incredibly closely.
And you mentioned group beta streptococcus GBS. That's screened for routinely, right?
Yes, it is. All pregnant women should be screened via vaginal rectal swab around 36 weeks gestation. If a mother is GBS positive, the standard of care is to receive intravenous antibiotics, usually penicillin G, during labor.
To prevent transmission.
Exactly, to prevent early onset GBS disease in the newborn. The exception might be if it's a planned C-section performed before labor starts and membranes are intact. Even with treatment, nurses still need to assess the newborn for any early signs of GBS infection, which usually appear within the first 12 to 24 hours.
Okay, switching gears slightly, but still on maternal influence. Infants born to diabetic mothers, IDMs, present a unique, complex set of challenges you mentioned earlier.
They absolutely do. For the infant of a diabetic mother, IDM, there's this interesting, almost paradoxical physiology at play. Maternal insulin cannot cross the placenta,
Okay.
but glucose does very readily. So if the mother has high blood sugar, the fetus gets exposed to high glucose levels. The fetal pancreas responds by producing extra insulin. This fetal hyperinsulinism acts like a growth hormone.
Making them LGA, like you said.
Precisely, leading to LGA or macrosomia, often with enlarged internal organs like the heart and liver. But here's the critical twist. That high fetal insulin level also decreases surfactant production in the fetal lungs.
So they're big, but their lungs might be immature. Risk for RDS.
Exactly. Increased risk for respiratory distress syndrome. So the nursing assessment for an IDM includes checking for LGA, signs of birth trauma from being large, like shoulder dystocia, assessing for congenital anomalies, which are slightly more common, checking for polycythemia and hyperbilirubinemia, and most critically, assessing for hypoglycemia. Once the umbilical cord is cut, that high glucose supply from the mother stops abruptly, but the baby's pancreas is still pumping out high levels of insulin.
So their blood sugar plummets.
It can drop very quickly and dangerously low. Nursing interventions involve meticulous blood glucose monitoring, starting within 30 minutes of birth, then hourly, then every few hours for at least the first 24 hours following protocol. And the first and most crucial intervention to prevent or treat hypoglycemia, early and frequent feedings. Get that glucose into them orally. If the infant is unable to feed effectively or glucose remains low, interventions might include buccal, 40% dextrose gel, or starting an IV with D10W, 10% dextrose in water.
Got it. Early feeding is key. Lastly, let's address the consequences of maternal substance abuse. These can be profound for the newborn and require highly specialized nursing care.
They certainly do. Neonatal abstinence syndrome, or NAS, is a major concern. It results from the fetus being repeatedly exposed to drugs in utero, leading to physical dependence. Withdrawal starts after birth when the drug supply is cut off.
And this increases other risks too.
Yes, maternal substance abuse increases risks for spontaneous abortion, preterm labor, IUGR, and stillbirth. When the baby is born, nurses assess for a wide constellation of NAS symptoms.
What does withdrawal look like in a newborn?
It can be intense, extreme hyperactivity, jitteriness, tremors. They often have a very characteristic high-pitched, shrill, persistent cry, frequent yawning and sneezing, nasal stuffiness, sometimes respiratory distress, sweating.
Sounds miserable.
It is. Severe feeding difficulties are common. Poor coordination, regurgitation, vomiting, sometimes diarrhea, which can lead to skin breakdown around the perineum. You might see increased rooting, but ineffective sucking. They often have a huge need for non-nutritive sucking. Developmentally, they're at risk for delays.
That's a huge list of signs.
Yeah.
How do nurses possibly intervene to provide comfort and care for an infant going through NAS?
Nursing interventions are really focused on supportive care and minimizing that withdrawal stress. We position the infant on their side sometimes to help with drainage of secretions. Small, frequent feedings are usually better tolerated, often holding them upright during and after feeds. A huge part of care is decreasing environmental stimuli, dim lights, low noise levels. Swaddling tightly provides comfort and security, reducing tremor.
Like a constant hug.
Kind of, yeah. Careful monitoring of intake, output, and daily weight is essential due to feeding issues and potential dehydration or poor growth. We often obtain meconium and Adora urine samples for drug screening to confirm exposure. For severe withdrawal, medications might be needed, often opioids like morphine or methadone, sometimes phenobarbital, following specific scoring tools and weaning protocols. And offering a pacifier for non-nutritive sucking can be incredibly soothing for these infants. And we can't forget fetal alcohol syndrome, FAS, another devastating consequence. Alcohol freely crosses the placenta and acts as a teratogen, interfering with fetal development, especially brain development.
What are the key assessment findings for FAS?
Nurses assess for SGA, often with characteristic facial features, things like small eye openings, a smooth philtrum, the groove between nose and upper lip, a thin upper lip, sometimes maxillary hypoplasia. Behaviorally, these infants can be very irritable, hyperactive, have a high-pitched cry, poor feeding, and persistent vomiting early on. Long-term, they face significant risks of cognitive deficits and developmental delays.
And interventions, similar to NAS.
Somewhat similar in terms of supportive care, reducing environmental stimuli, swaddling for security, managing irritability sometimes with sedatives if ordered, and focusing on maintaining nutrition and hydration despite feeding difficulties. But the underlying brain changes are permanent, so long-term developmental support is crucial.
We've covered such a vast landscape today, so many challenges high-risk newborns can face, from the delicate balance of prematurity and size to the really profound effects of maternal infections and substance abuse. It's truly a testament to the intricate dance of life and the dedicated, meticulous nursing care these tiniest patients require.
It really is. This deep dive highlights just how crucial that meticulous nursing assessment is, how vital timely intervention becomes, and why a holistic understanding looking at both the baby's physiology and the maternal factors is absolutely essential. Every detail, from the sound of a baby's cry to the exact timing of jaundice onset, holds critical information that guides potentially life-saving care.
Absolutely. So, considering everything we've discussed, all the factors that can contribute to a newborn being high risk, from their own biology to the environment to the birth itself, what stands out to you as maybe the single most impactful nursing action? The one thing that really sets a high-risk newborn on the best possible path forward? And maybe, thinking beyond the immediate care, how might we further empower families in understanding all these complexities? How can we help them truly become active, informed partners in their baby's care team, especially when things feel so overwhelming?